So thank you, Sarah, for agreeing to do the presentation. Really appreciate it and know you're busy. But Sarah is our consultant colorectal colleague who, fortunately for us, has got a special interest in complex pelvic surgery. Now, Sarah not only is an experienced laparoscopic surgeon, but she's also done her fellowship in advanced pelvic malignancy as well. So, and she's part of our endometriosis team in our MDT because yeah, she's an asset. Thank you, Sarah. Over to you.
Thank you very much for that kind introduction.
Not at all.
And thank you for inviting me to speak today. Can I ask, can you see the slides okay? Okay, great. So as Sybil has rightly said, endometriosis has become a part of my regular practice. And so today the aim is to give you an overview of colorectal input into endometriosis and how we work as a unit to achieve a well-planned, executed service. So there's inevitably been an evolution of the service. We've moved from sort of ad hoc phone calls and unexpected events such as bowel resection and patients requiring stomas to now pre-planning these anticipated difficult cases that may require input from other specialties. As everybody is probably aware, there is an increasing awareness of the condition through social media, and about 7 to 10% of the female population will be diagnosed with endometriosis in their lifetime. And as we've just discussed, it does cause anatomical distortion and adhesions that can lead to severe symptoms, which can have a genuine effect on patients' quality of life. So I think from a clinician's perspective, we need to consider these cases quite carefully. Obviously, the aim is to achieve symptom control, but we're also mindful that these are young patients with benign disease, and there is significant morbidity that's attached to surgery. And these need to be carefully considered and communicated to the patient prior to embarking on surgical management. So the GI tract is the most commonly affected extragenital organ, and this occurs mainly in the pelvis at the rectosigmoid or rectovaginal septum. Patients will often present with symptoms of dyschezia, dyspareunia, rectal bleeding, and pain on opening their bowels. So MRI scanning is a useful imaging modality to assess the extent of pelvic disease and involvement of surrounding structures. Superficial lesions are typically located on pelvic organs or on the pelvic peritoneum and don't require any colorectal input. The second category of patients are those with deep infiltrating lesions into the bowel, and these can often be illustrated on MRI scanning, which is actually sometimes more useful than a diagnostic lap when looking at rectovaginal disease. So these patients should be then discussed in the MDT for planning and colorectal input. There's then a third category where there is a suspicion of possible bowel involvement that may or may not require colorectal input. And the way we do this in our unit is to often put those patients on our radar, and I can be on standby if and when needed. So although there can be significant morbidity associated with colorectal endometriosis surgery, there are clear benefits that are reported in the literature, including symptom improvement and improvement in quality of life for the patient. The data regarding fertility is a bit patchy, but there does appear to be some increasing data and evidence for this. Potential complications, for example, leak, stenosis, and fistula formation, as well as dysfunction in urinary and bladder function, are usually secondary to nerve injury. Obviously, these are very serious complications, but actually quite rare. So in terms of surgical techniques that are described, there are 3 different options. Shaving generally involves dissection of the nodule without breach of the mucosa of the bowel. And this can be achieved either with sharp dissection or CO2 laser or using the harmonic. And subsequently, if you have gone slightly deeper than anticipated, you can repair this with sutures. Discoid resections involve full thickness resection of the anterior wall of the rectum, followed by a 1 to 2 layer closure or closure with a stapling device. And resection is the other option, which can be performed with a primary anastomosis. Generally, it's better to do a limited segmental resection and try to stick within the mesentery or close colonic, as we tend to do with other inflammatory bowel conditions, because this can help to avoid the neurovascular bundle and then preserve function. So Oberau et al. Has described an algorithm for decision making regarding surgical technique depending on the size of the nodule, extent of the disease, and the degree of involvement into the bowel. And you can use this as a sort of guide to guide you when you're making decisions intraoperatively. I've sort of decided to mention rectovaginal disease separately, as I think this is obviously more tricky surgery and has increased morbidity. There is a lot of data and opinion pieces that suggest a more conservative approach for these cases might be appropriate. Dissection to free the lower rectum involves a posterolateral approach, and the pararectal spaces are then opened longitudinally and medially from the ureterosacral ligaments and from the inferior hypogastric plexus to isolate the anterior compartment prior to dissecting the nodule. And it's at this stage that the autonomic nerves are at increased risk of injury, which can lead to dysfunction. The other issue is that if these patients require resection, low anterior resection is obviously more risky in regards to risk of anastomotic leak and also risks of fistulation when you compare it to high anterior resections. And it would be my sort of choice with these patients that they'd almost certainly require a temporary ileostomy to protect the join. It's also sort of in the literature that actually, despite segmental resection, there are still a proportion of those patients where the margins are not clear of endometriosis. And the literature dictates that about 95% of deep endometriosis in the rectovaginal septum can be managed with shaving and expert hands. The wall of the rectum is actually thicker and is therefore a bit more forgiving of shaving. And in colorectal surgery, we do have quality markers that we use to assess the blood supply when we do an anastomosis, and also to have a look at the actual anastomosis postoperatively. So we use ICG to assess blood supply, and we also use a flexible sigmoidoscopy intraoperatively, which works to do the leak test and also allows you to have a look at the join. And I think the same can be applied in these patients having endometriosis surgery. So reported surgical outcomes are good. All three different techniques have been shown to improve symptoms of dysgeusia, dysmenorrhea, and dyspareunia at 6 and 12 months. However, this particular study has shown that recurrence rates are significantly lower with shaving compared to segmental resection. And as I've previously mentioned, the data regarding fertility is patchy, but some studies have shown improvement in fertility rates up to about 50%, particularly in younger women under the age of 35. But there's obviously some more work to be done to have a look at this. And in regards to complication rates, they are higher amongst segmental resection and disc excision, and outcomes including fistulation, leak, and bowel dysfunction have been shown to be lower amongst the shaving cohort. So coming back to functional outcomes, as I've said, I think these are often related to quite aggressive dissection of the lower rectum and pararectal space. So the avoidance of radical excision in the dissection of the sigmoid and rectosigmoid can improve functional outcomes by avoiding the superior hypogastric plexus, and the same applies for the inferior lower down. And low anterior resection syndrome is a recognised condition amongst the colorectal community, and it can be a problem in patients who are undergoing extensive surgery for colorectal gynae endometriosis, particularly those with transvaginal disease. And this condition is reported to have quite a significant impact on a patient's quality of life. So this study shows a clear correlation between higher LARS scores and a negative impact on quality of life. Just to go back to explain that, so the low anterior resection syndrome score is basically compiled of 5 important questions to the patient, and then there's a final score of 0 to 42. And the higher the score, the more likely they are to have major low anterior section syndrome. So this large Dutch study includes about 100 patients and has shown no difference in bowel symptoms postoperatively. However, impact on sexual relationship was significantly higher in women who were undergoing segmental resection as opposed to shaving. And as with any complex surgical disease, high volume centres have been shown to have better outcomes with fewer complications. Laparoscopic approaches have also been shown to be superior in terms of blood loss and also serious complications. And there's also a decreased length of stay in those patients. There are some studies which do also show that there are improved fertility rates with laparoscopic approach as opposed to an open approach. So I'm going to take you through each stage of our perioperative management for these patients who have suspected bowel involvement and the considerations that we think about at each stage. As I've previously mentioned, staging can be done with a combination of MRI scan and diagnostic laparoscopy. I think there is sometimes value in doing a flexible sigmoidoscopy preoperatively if there's a concern of deep involvement of the rectum or sigmoid. In order to assess the mucosa itself. And I think this can help you then plan whether or not a patient is likely to require bowel resection as opposed to shaving. So all our complex patients are discussed in the MDT, and we have a specialist radiologist who takes us through the scans, and we're all sort of present as a team of clinicians of different specialties together. For those patients who do require extensive surgery, they are seen by both the gynecology team and the colorectal team. And I think there's sometimes value in seeing the patient together in a joint clinic. It's helpful in the sense that at this time you can also make decisions about planning for theatre time and space with both teams present at the same time. And importantly, any patients who are likely to have a bowel resection need to be counselled accordingly. So those with rectovaginal disease should be reviewed by the stoma team in order to achieve adequate counselling about managing a stoma and the impact of a stoma on quality of life. With any patients who have disease like this, I would always give them mechanical bowel preparation preoperatively because in the event of having to perform a low anterior resection, there is no value in defunctioning with a stoma unless the colon is empty. Otherwise, it doesn't help to reduce the consequences of a leak. There is also evidence that suggests that antibiotic cover during mechanical bowel prep can help to reduce postoperative wound infection and leak rate. And so we provide this for our patients as well. So what's the value of the MDT? Well, I think it's vital in these patients. It enables a good relationship to be built between different specialties and then consensus to be drawn about treatment of each individual patient. It also enables the opportunity to highlight patients who might need bowel resection. And so in essence, it's a sort of essential step in enabling successful preoperative counselling and planning for the patient. So intraoperatively, there are a few important considerations. Endometriosis is an inflammatory disease and there are no clear planes. So even for an experienced pelvic surgeon, it can be quite challenging surgery as opposed to malignancy where the planes are usually quite demonstrable. Gynecology would usually begin the procedure and then often we would go next, and sometimes it can be difficult to interpret the planes if you're not starting from scratch. So I think it's really important to think about, are you comfortable? Are your ports in the correct place that you can do what you need to do? Is the table height right? And do you have all the instruments that you require present, particularly if you need to do a resection? So I think all of this should be pre-discussed in the WHO before the patient comes to theatre, and consider things such as adjuncts like rectal sizers and flexible sigmoidoscopies and stapling devices. The last thing that you want is your team and yourself stressed because they're running around trying to locate bits of kit last minute. And often bowel decision making regarding technique is actually made intraoperatively, depending on the degree of involvement of the bowel. I think it's always worth considering non-radical resections to preserve the nerve and blood supply for improved outcomes. And I think it's also really important to think about each patient as an individual. So what's their symptoms? What are their treatment goals? And actually, do they have any sort of real adversity to things like a stoma? So I think those patients may choose to sort of incompletely treat their disease rather than run the risk of having a stoma. And it's important to elicit those things beforehand. And in some cases, I think it's may also be worth considering a stage procedure to see if the patient's symptoms do improve, as some endometriosis that's left may regress with a combination of medical and surgical treatment, and have a view that obviously if symptoms do not improve or worsen, the patient can come back for further surgery. And post-operatively, generally, I think patients can be managed on a gynecology ward. However, I think in cases of bowel resection, it's ideal to have them taken to a surgical ward just because the nursing staff are used to managing these patients, and in regards to things like the ERAS protocol, and also just looking out for signs of an anastomotic leak. And generally, I think together the team just needs to have a consensus decision about adjuncts such as things like drains, and whether decisions about taking those out should be made by the gynecology or colorectal team, because I think there'll be kind of quite few certain circumstances where actually those decisions must be made by colorectal. So just before sort of finishing, I just wanted to mention that actually some centres are now performing these procedures robotically, and so far the outcomes have been quite good. I think the endometriosis lends itself to the robot in the fact that we're managing and treating very difficult pelvic disease, and the instrumentation and 3D imagings are quite useful in enabling precise dissection and avoiding things such as disruption of the neurovascular structures. And I think that in time we will see more centres adopting the robot for these procedures. So in summary, I think it remains a work in progress. There has been an evolution of the service, and I think it continues to evolve. Outcomes are better in high volume centres with consistent teams. And I think all complex patients need to be discussed in MDT, and pre-planning is vital. And finally, I think communication with each individual patient in establishing their treatment goals and acceptance of risk with good documentation of that is key to good outcomes. Thank you very much.
Thanks, Sarah. Very excellent talk, comprehensive, interesting, and it reflects the complexity of what we do and your input. Just one comment before we listen to questions is you said there's always an element of decision to make jointly during surgery, and that's one of the things about endometriosis. We do the MDT meeting, we listen to the radiologist, we talk to each other, we look at the images, and we put a plan that this patient will need this, and that. But always there's a decision to actually go in, put the scope, and then make a decision to shave, to resect, or to do a disc. And I think it's interesting that you will only know when you are there. But there are two schools generally, and I think we've had this discussion a few times. As a conservative school, which are just relevant to some of the slides that you mentioned, and the radical school, they believe that you have to take every inch or every millimeter of endometriosis, even if you have to chop a large part of the bowel. In the UK, as far as I know, we are more toward the conservative school, and as you've shown the data, the less radical you are, the less risks and leaks and fistulas and all that kind of things. The only controversy that you mentioned, I think in Europe, in some Italy, Germany, France, I think they're more radical. And if you go to conferences and see live live surgery. They're just more radical in terms of excision and bowel resection and things like this. But the only controversial issue you mentioned is if we leave some disease, and I know many will disagree with this, that it may regress, it may not cause problems, but I think this is an open question. On balance, sometimes we err on the side of caution. If we leave few bits behind and avoid bowel injury, fistula, leak, that's probably better than being more radical and then risking major catastrophe. But it's a very good presentation. Welcome to the show.
Yeah, thanks. I think I agree with you, and I think that's where it becomes really important to have the discussion with the patient, because there are some patients who would actually choose to be more conservative because they just dread the thought of having any of these complications. And then I think there are some patients who will have, accept that risk and have any treatment just to get rid of their symptoms. And I think we've done a couple of cases, where sometimes we've sort of felt that actually, again, you can do a staged procedure with these patients and, do a sort of limited, more conservative approach to start. And if the symptoms don't improve, then obviously we can come back another day.
But this goes against the guidelines. We should resect completely. This is where we are.
Yeah. It's still a work in progress for me too, I think.
I think that's a similar sort of discussion that the ones that have been happening in oncology over the last 10 years, because again, oncology was much more conservative in the UK compared to the rest of the world. And there's been a transition to have complete resection. But again, I think, as you rightfully say, Sarah, the biggest thing is patient counselling and appropriate discussion, because some patients will say to you, look, I want rid of the entire disease, the symptoms are too bad, and I accept whatever. And it's balancing that morbidity versus, mortality on cancer, but obviously symptom control in endometriosis. And I think the endometriosis pathway is following a similar sort of pattern to what's happened in oncology. So I suspect people are going to become more radical. There wasn't an MDT meeting before, there wasn't multidisciplinary working. But I think, patient counselling is going to be central to that.
So I take it, Sarah, then that you are prepared for a high volume work.
Yes. Ready to go.
You are committed now.
No, absolutely. I do think the only difference
loads
between
of patients waiting, so be prepared.
Sorry, Sarah.
I was just going to say, I do think the difference between the kind of, I know what you're saying about, oncology and you're right, but I think that you also have to think there's a difference between a patient who has cancer, so it's a radical resection, and a patient who's got benign disease.
Absolutely, but I'm just saying the sort of pattern we're seeing is a similar sort of transition. And I think if we're going for symptom control and things, then that's a general transition with multidisciplinary working. And increased radicality. Sorry, but I wasn't saying to be more radical.
No, I agree. I know what you mean.
Right, thank you very much. Any other questions? Hold on, there's a question from.
Just to let you know that Mr. Mabrouk is joining shortly, so we can he should go for next. Mr. Mabrouk.
Just give me 1 second. So somebody's got a question. Ahmed Nagar. Ahmed, do you want to ask your question?
Sorry, Sarah, thanks for this presentation. Just in case if we open the vagina with the bowel resection at the same time, whether we just excise a deep vaginal nodule or hysterectomy at the same sitting, do you recommend to do like an omental flap just to intervene between the two anastomotic areas just to reduce the risk of fistula? And if we do this, do we need to suture it? And if we suture it, do we suture it to the vagina or just to the bowel serosa to reduce the anastomotic leak?
That's a very good question. So when we've done it previously in cancer patients, we have used an omental flap, but we don't really suture it. We just mobilize it all and put it down in the pelvis. But I think that's the other reason behind my personal feeling that these patients should be defunctioned, because that just allows time for everything to heal before putting any bowel content through the actual joint, so should hopefully reduce the risk of fistulation.
But do you defunctioning all of this patient, or if just you do a low resection like 5-6 centimeter from anal vag?
So I think anybody who has a low resection, you've got vagina closure of vagina, suture line, and you've got a bowel anastomosis next to each other, I think they should be defunctioned.
All right.
Yeah.
Okay. Thanks.
Okay. Thank you.